Okay. Well, thank you everybody for joining us today. We appreciate you taking some time out of your busy day so we could introduce our new gastroenterologist, Joseph Runde. Dr. Runde comes to us from the University of Medical Center where he did his fellowship in pediatric gastroenterology. He has some clinical interest, including inflammatory bowel disease, which he'll speak about today. And Dr. Runde, he'll be seeing patients at Arlington Heights, Northbrook, and our new Skokie facility. Our new Skokie facility, as you may be aware, is opening on November 23rd, located at 3722 West Toohey Avenue. We're going to have plenty of services there, such as allergy, dermatology, endocrine, gastro, genetics, neurology, pediatric surgery, sleep medicine, urology, some great wraparound services like cardiology and echo, orthopedic and sports medicine with medical imaging, ultrasound, CAS care, and then very excited to have ENT and audiology at the same place together. Other services we're going to have is going to be blood draw and lab services, medical imaging and ultrasound, and physical therapy. So we're very excited about that. We're going to have plenty of new physicians that are going to be opening up access to all of you. If anybody is interested in meeting any of our specialists, please either go ahead and let me know by email, phone call, or even put in the chat room today. Speaking of the chat room, I encourage you to ask questions as Dr. Runde is going along with his presentation. If you have any questions for any of us, I will go ahead and ask them as an on-need basis. So, but without further ado, I'm going to send it over to Dr. Runde, who will start the presentation. And go ahead and take it away.
All right, sounds great. Thank you, Chad, for the introduction. And for anyone logged on, thanks for being here with us. And hopefully some of you will be able to get this remotely or after the fact as well. As Chad said, I'm coming from the University of Chicago, so that's where I had done my fellowship. And so, you know, I'm not new to the city of Chicago, but definitely new to the northwest suburbs and getting to know it out here. So I hope to get to know some of you pediatricians that are in the area as well. Yeah, we can go to the next slide. I just start off with a little bit about me. I actually had cut some of this out, so I apologize if you're getting a heavy dose of Iowa here, but I'm from Iowa and have a lot of Iowa State pride. I'm from Cedar Rapids, which is in the picture there, the city of 5 seasons, which I actually only recently learned the 5th season is one to enjoy them all, which is pretty corny, but that's where I'm from. I think you can click next for us, Chad. It also has the world's largest cereal factory, which is Quaker Oats. So the city often smells like crunch berries. And they made a movie about Cedar Rapids, which is pretty much just making fun of Cedar Rapids as being sort of a pretend big city. And then the other thing, Chad, you can click next, that we're famous for is natural disasters like floods that happen every 5 to 10 years, or recently you may have heard over the summer about the derecho. You can click next, Chad. I think some of the pictures of the floods and the derecho, which literally uprooted like trees that were hundreds of years old in about a 10-minute severe windstorm. So the next slide I had cut out, but it's a little bit more about Iowa, just to really hammer home my love. So Field of Dreams is set in Iowa. So there's a famous iconic quote about, is this heaven? No, it's Iowa. And then the actor on the other side there is Ron Livingston, who's from the same town as I am. And I actually bought my dog when I was little from his family. We have some cool celebrities, but also terrible politicians. That's Herbert Hoover there, who's often regarded as one of our worst presidents. He's from Iowa. So anyway, I can go into the actual meat of the talk now. So this is actually 2 studies that I have worked on that are currently in prep for publication now. One of them, and I just wanted to highlight this point, is about pediatric ulcerative colitis. And the key thing here is that it in some children, it has a really aggressive phenotype. So you can go to the next slide. This is clinical research that I had done with David Rubin, who's a fairly prominent IBD doctor in Chicago and around the nation. And we were looking at children with ulcerative colitis who actually had such severe disease or disease that didn't respond to medical therapy that they required a colectomy. And then the procedure for treating that is removal of the colon and then creation of a pouch with the end of the small intestine that creates like a reservoir and allows kids to be put back into continuity after the surgery. You can click next. So there's a lot of data out there for adults. There's not so much data in children, and the data that's out there is often kind of heterogeneous with different preoperative diagnoses like familial adenomatous polyposis syndrome. So we wanted to look at just children and just specific UC for outcomes, and we had about 53 children, which we defined as people less than 19 years of age that had undergone colectomy for ulcerative colitis, and we compare that against 330 adults. So we can go to the next slide. I'll show you some of the key findings from this research. So one is that for the children, which are the black bars in this case, compared to adults, there's a much higher need for post-operative aggressive biologic therapy. And one thing that we've often said about ulcerative colitis is that if you take the colon out, the disease is cured. But some people end up having ongoing inflammation even after their colon comes out, or they have a change in diagnosis to Crohn's disease later on. And this would suggest that children have more complications after the surgery and often need therapy after the surgery, and possibly may also have more change in their diagnosis after therapy compared to adults. And then also children may go on to lose their pouch, which is that end of the small intestine that creates sort of a new rectum, a neorectum for them. But if their disease is severe enough and the pouch doesn't work, then they end up getting permanently diverted, so having a permanent stoma. And that seems to happen more in children than adults. And you can click the next slide. And then this was a really interesting finding from the study. We actually looked at over time, what is the prognosis of colectomy and creation of a pouch for children. And in blue, we have children from our study that underwent their procedure in the 1990s, and green is 2000s, and red is 2010. You can see that over time, pouch survival decreases, so that for children who underwent their colectomy and pouch creation in the last 10 years, by about 5 years, 1 in 4 of them will have lost their pouch. So it seems to be that in more recent decades, your prognosis is actually worse. You can go to the next slide, Chad. So, you know, we're still prepping this manuscript, but the big things we found are that, you know, for children that have ulcerative colitis that requires surgery, there's a higher likelihood that they're going to need aggressive therapy even after they have their surgery. And there's a higher chance nowadays that they actually will have pouch failure and require a permanent ostomy. You can click next. And that the decade of their IPA, of the pouch surgery, will predict their outcome to some extent. And then last thing here is that the prognosis for children with UC that require colectomy and pouch creation in the modern era is worse compared to adults. So that was kind of the clinical research that I wanted to share with you that I've been working on. And this is a little bit of the basic science research that I've been doing as well. Also, this manuscript is in preparation now. And probably a lot of you joining on the call here have experience with patients of your own who have Crohn's disease, and maybe some of them have been on dietary therapy. But it's this really cool thing in pediatric Crohn's disease that there's really great evidence behind using dietary therapy to control their inflammation. So you can go to the next slide, Chad. The time-honored therapy is called exclusive enteral nutrition, which is replacing your regular diet with fully formula diet for about 8 weeks. And in children with Crohn's disease, usually mild to moderate and not so much the severe Crohn's disease, when they get diagnosed or they have a flare, you can actually treat their inflammation by just replacing their diet with formula for this period of time. And that you can click next here, Chad. I think I was just showing one of the seminal studies here. Click next. Not only do their symptoms get better, which is what this chart here is showing, but when you actually do biopsies and look at their histopathology, it actually improves better in dietary therapy, this EEN, than it does in giving children steroids. So it's really, really remarkable thing. We're learning more about it and how to use it more. It's very popular in Israel and Western Europe and not used so much in the United States. But the research that I have been working on focused on this therapy. You can click to the next slide, Chad. And we looked at children with samples, so stool samples with Crohn's disease who went on this exclusive enteral nutrition diet at various time points. Go ahead, click the next slide there, Chad. Click next. So there's samples before therapy, next please, during therapy, and then clicking through here, followed up after they had completed their therapy. And then we looked at the microbial, like the bacterial populations at each of these time points in these children. Click to the next slide here. I apologize, all the animations, I meant to be driving this myself, and I was having some technical difficulties, but what we found was there's characteristic behaviors for bacterial populations in children undergoing exclusive enteral nutrition. And what you see here in the columns are a given bacterial population. We didn't give them names here. Click next, Chad, but we measured their abundance, which you can see in these dark boxes here, at time points before, during, and after therapy. And then we put them into categories of behavior, phenotypes, we call them, sort of based on what these bacterial populations were doing. And we came up with 5 kind of distinct phenotypes. Go ahead and click next, just to get the final animations up here, Chad. But you know, really interesting stuff where there were some bacterial populations that were there before and after therapy, but completely went away during this exclusive enteral nutrition. And then also populations that only bloom during therapy and they weren't there before or after. Those are the ones we really focused on in this this study. And then we mapped these. Go ahead and go to the next slide. These particular bacteria in healthy children, and we found that for these populations which become suppressed during exclusive enteral nutrition, they're very well detected in healthy children. But for these other ones that bloom only during therapy, you can see here in the ephemeral bloom category, there's almost no detection at all. So just summing up kind of our findings of this study in very plain terms, go to the next slide, please. That, you know, this really great dietary therapy that seems to work in Crohn's disease probably works by disrupting a selective advantage of really common gut bacteria. And that there are blooms, these ephemeral blooms of gut bacteria that are really not so common, that come in during exclusive enteral nutrition. Those were the ephemeral blooms in the orange on the previous slide. And we know that dietary therapy in pediatric Crohn's disease is going to have a bigger role moving forward. There's a lot of diets that actually attempt to mimic EN, this exclusive enteral nutrition, but allow you to eat regular food-based products that are being studied right now. And that might help with us using it a little bit more in the US. There's a lot of interest from families about doing this too. And there's even some idea that there may be children with pediatric Crohn's that don't respond to even our biologic therapies that would respond to diet. So we're learning a lot about this. And you go ahead and go to the next slide, Chad. I'm done. I'll just kind of sum up that you know, I hope to be growing you know, the IBD clinical population here, and we're hoping with a couple of new providers, myself and Dr. Wenzel, that, you know, if you do have any patients that you're suspecting may have IBD, you know, we really would hope to see them at this point within a week of you all reaching out. So please feel free to contact us. And moving forward, I hope that we'll be able to develop a clinic for patients with IBD specifically interested in dietary therapy. That's even more of a niche clinical interest of mine within the IBD category. So thank you for your time, and I'm happy to answer any questions if there are any.